Hello, welcome again to RC-558, Special Topics in Rural Rehabilitation. This class we're going to be discussing the medical and psychological restoration in rural areas. So please make sure for this class you have downloaded the PowerPoint slides entitled Medical and Psychological Restoration in Rural Areas. In this class, or this lecture, we're going to be discussing some of the specific issues related to the challenges to providing medical and psychological restoration. Some of the statistics are out there, the shortages, the issues, some of the strengths that are out there, and then also probably in part two, we will discuss some of the efforts that are underway to sort of close the gap and address some of these issues in proposed and current legislation, such as the Patient Protection and Affordable Care Act. So, leading off, we look at, started off there with slide 2. Robert Bowman talks about physicians and talks about physicians who happen to be drawn to rural practice, and they want to make a difference in people's lives and want to have a respected position where they care for a town and the town cares for them. Also, the second quote there by Dr. Levitt L. Dunbaben talks about the medical literature has consistently shown that a rural background is the single most significant personal characteristic influencing doctors' decisions to practice in a rural location. This lecture, we're talking about access to health care and access to services, which is the crux of sort of a given when we introduce students in our introductory courses to the foundations of rehabilitation, and we introduce students in case management. There's always this assumption that if the service is needed, it will be available. I can remember when I was trained as a graduate student, it was just we were always under this assumption that we were to be more concerned with a needs assessment of the consumer, not necessarily about the quality or the availability of the services. There was just always this assumption that would be available. Well, in rural areas, that's not necessarily the case, and in fact, some of the statistics we're going to discuss later are going to indicate that there is a shortage. And of course, one of the great things that these quotes allude to is that though we don't want to discount those individuals that are working in rural areas, that they have chosen to be there, that a lot of times they have a civic responsibility. A lot of times they will go above and beyond. And they've prepared for being a rural physician their entire life. So we'll discuss the good and bad of this availability, but it's important to understand that there is a difference between health care offered in a rural setting versus that of its counterparts in urban settings. So let's talk about what is different. On slide 3, several statistics there. I'll go through a few of them. Only about 10% of physicians practice in rural areas, despite the fact that nearly 1/4 of the population lives in these areas. So the issue being, even though there's quite a few people, many times physicians don't want to relocate or live in rural areas. And it may be the fact that there's just not enough people in the area to make a practice viable. So they live in urban areas and have people from the rural areas drive in. Rural residents are less likely to have employer-provided health care coverage or prescription drug coverage. Rural poor are less likely to be covered by Medicaid benefits than their urban counterparts. In terms of employer-provided health care coverage, many times if there's only 1 or 2 large businesses that are employers in the community, they don't have to provide as competitive a benefits package as some of their urban counterparts, so that they don't have as good or any at all employer provided health care coverage. About 1/3 of all motor vehicle accidents occur in rural areas. 2/3 of the deaths attributed to these accidents occur on rural roads. So, you know, that doesn't necessarily have to do anything with access. It's just the issue with rural health care is that, you know, there's more at risk, people at risk for death. You know, if you ever lived in a rural area, you know that they're curvier roads. A lot of times people drive faster because there aren't stoplights, etc. A lot of times, you know, it's more likely people will have accidents where they would need rural medical assistance. Rural residents are nearly twice as likely to die from unintentional injuries other than motor vehicle accidents than are urban residents. Rural residents are also at a significantly higher risk of death by gunshot than urban residents. Rural residents tend to be poor. The per capita income is $7,417 lower than in urban areas, and rural Americans are more likely to live below the poverty level. And it's even worse for minorities living in rural areas. I think that the statistic that's a little scary is that 24%, 1/4 of rural children live in poverty. And you know, I think I've discussed in other lectures that in many cases the argument is that the cost of living may be cheaper, especially housing in rural areas. But in many cases, the cost for other services probably offset that cost of living or housing smaller amount. So, you know, it may necessarily break even. You know, even with reduced income and taking into account the lower cost of living, it's not that much cheaper probably to live in many rural areas when comparing it to their urban counterparts. So that $7,400 less per capita income is a large gap. There's a lot more reliance on the food stamp program in those areas. So again, adding to that, you know, there's more poverty. And 31% in 2001, 31% of the nation's food stamp beneficiaries live there. And you know, again, it's one of those. What's the cause? Why did that? You know, why is this amount so much? Is it because it's a rural area? Is it the people that live there? Is it because there aren't any jobs? And that's hard to sort out. But it's important to understand that it exists, and there's impacts on. You know, it impacts rural health care because people in poverty and lack of access to health care tend to have more chronic health problems and don't get preventative care. When looking at health professional shortage areas, we're on slide 4 here. In rural and frontier areas of all states and U.S. territories, 2,157 were identified in rural areas, and as compared to only 910 in urban areas. So when they looked throughout the United States at where there was a lack of health professionals in a given area, they identified 2,100 rural areas versus only 910 in urban areas. Abuse of alcohol, use of smokeless tobacco, DUI arrests, all considerably higher. I found this stat to be interesting that anywhere from 57 to 90% of first responders in rural areas are volunteers. And I would never downplay the role. Many times volunteers are every bit as good or better than paid staff. However, the fact that you don't have paid professionals as first responders that are professionally trained, that are required to be there as part of their job, that you're relying on a volunteer who, an uncertain staffing pattern when you're dealing with those groups, it's cause of concern. There are 60 dentists per 100,000 persons in urban areas versus 40 per 100,000 in rural areas. Again, that goes to lack of access, lack of preventative access causes more chronic problems. Cerebrovascular disease is much higher in non-metropolitan areas. Hypertension much higher in rural areas. Moving on to slide 5, when we talk about Medicare payments to rural hospitals, dramatically less than those in urban counterparts for equivalent services. And also, which, there's a problem because more than 470 rural hospitals have closed in the past 25 years. While it's always, you're always hopeful that there are altruistic people that are out there providing services. Let's face it, when you're dealing with private hospitals, private physicians who run businesses, they expect to do so and make money. And if many of them, if they have to work 60 hours a week and make $100,000 a year, they're more likely to go someplace where they can work 40 hours a week and make 150, or 60 hours and make 300. In the end, while altruism is wonderful, and loyalty is still there in many, the draw, especially when you have so many physicians and other professionals out there that come in with such high debt loads, they have to make money. And if they can't make money in rural areas, then they go to urban areas where they have a better opportunity. Persons with acute myocardial infarction, which is a heart attack, were less likely to receive recommended treatments in rural hospitals, and had a higher death rate. Rural residents have greater transportation difficulties reaching healthcare providers, often traveling great distance to reach a doctor or hospital. When you have something acute happen, seconds, minutes make a big deal, and if you have to drive 30 minutes to an hour to get to an acute care center, those are precious minutes that could be losing treatment. Or if you're just receiving just regular treatment through a physician and you have to drive an hour, 2 hours, I think that's not hard it's not a big leap to understand that is a significant burden on the person that's receiving healthcare treatment. So, I think we make a good case here that there are significant differences and there are significant issues related to access to health care, and some of the issues also just in differences in the population between the groups. Lack of access, lack of, more higher risk for injury and death and disability, lack of preventative care. So there's a strong case that exists. Let's talk a little bit, and that was the medical aspects. Now let's talk a little bit about rural psychology. Because if there's anything that's even farther behind rural medicine, it's rural psychology, because it is a newer field. As long as there's been small towns, there have been small town doctors. There's not always been small town social workers or psychologists or rehabilitation counselors. You live in small communities where you have a lot of people doing farm work and physical work and strength. The strength of the person, the character of the person is. You're expected to be strong. The community know the individuals, and a lot of times that it's taboo to discuss seeing a psychologist or a counselor. So if anything lags, if there's any one medical field or field that lags behind rural medicine, it's rural psychology. on slide 6, we discussed some of those issues, and I think one of the things and this is a little older, it's 2001. I would doubt that this number is much higher, but this is really scary to me. That 55% of U.S. counties have no psychologist, psychiatrist, or social workers. So not only do they not have, we're not just talking about the lack of quality. I mean, they have the lack of access to anything, which is very concerning. Because we understand, we know that just because they don't have the access, that doesn't necessarily mean there's not a need. There's a great need, and many times if you have people that have suffered a traumatic injury or disability, they have, there's adjustment. There are all sorts of disabilities. There's high rates of disabilities inside these areas, and no one to address those issues. Which, of course, what ends up happening is many of these problems get pushed to the general practitioner, who of course tends to prescribe medication or utilize other medical treatments to address psychological issues, because that's the service that they have available. We talked about a little earlier, but 20% of Americans live in health professional shortage areas, and this includes psychologists, counselors, social workers, etc. There are some strengths, and it's important to understand that with these strengths, or with these issues, there are strengths, and if you are a psychological practitioner in a rural area, there are things that you can work with. One is that there's a stable community. The backbone of the community has been there for years. It'll stay there. There's not a lot of rise and fall in the economy. They're usually fairly stable. The people are there. There's not a large transient population, so there's a chance for some continuity in treatment. It's important to understand that also there's strong community and extended family ties. There's a lot of support that's out there, and if you learn to utilize it correctly, and if you get lucky, that it's a proactive, supportive, not a codependent community or family, or a enabling community or family, that you can use that as a strength and use that to your advantage. Some of the other challenges is, again, we talked about rural poverty, but just the stigma associated with psychological treatment is greater in small communities. If you're in a small town of 3,000 to 5,000, and you're a psychologist and you have an office in downtown, well, if somebody walks in or out of your office, they're going to know that likely you're receiving treatment, and they're more likely to know, or that person, they're more likely to know them and know their family, and it's harder to maintain that confidentiality, so people may not even want to come near your office because they don't want to be perceived as being weak. Another challenge, which we've discussed, it's on the slide here, is rural clients have fewer employment opportunities. And we've talked about that in a lot of different ways, but if you look at it from the psychological aspect, if you're a person and you have a disability, be it late onset or developmental, and you can't get a job, therefore you lack purpose in life, you're more likely to have depression. That's where issues such as alcohol and drug abuse and other types of illegal activities sort of creep in. So it's important to understand, if you're looking at, we've always talked about it from a service or approach, but if you look at it from the individual trying to find employment, the impact psychologically on them, that's a big hurdle you have to deal with. That the lack of the ability to get a job causes psychological stress, and there's a lack of access to psychological staff or psychiatrists or social workers to address those issues. You have a high school dropout rates much higher, especially for whites and African Americans, not necessarily for Hispanics. And urban schools spend more per student than rural schools. So you've got a less educated, in general, community and population, which will impact their ability to receive treatment, to understand treatment, also to get jobs, get and maintain jobs, which again goes back to that psychological issue. Moving on to slide 7 there, as we sort of talked a little earlier, there's a shortage in mental health infrastructure and a supply of mental health professionals. Many, again, as towns evolve, there was always a town doctor. There may have just been one, but it existed. Hospitals existed. There was not and there was never any shame. There's no weakness in going to a hospital, or not like there is associated with mental health. So the mental health now comes along later, and for a population that's not wanting to accept it, plus being a smaller population that were to be fully utilized would be tough to would be tough to fully financially support. So not only do you have while you have a great need, there's not necessarily the demand nor the availability, because there may be a great need, but many people don't want to try treatment because it's of the perceived weakness. Therefore, there's not a demand for services. Even though we know that there are many people out there that require them, or there may be a high demand but lack of professionals that want to work in that area, because it's just like being a general practitioner. It's very difficult to specialize because you get such a wide variety that you have to sort of be a psychologist or counselor or social worker with a very general approach to mental health. You could be dealing with extreme psychosis to adjustment issues within the span of an hour. And many people don't want to do that. They like to specialize. They like to pick their particular population. Very difficult to do in rural areas. 20% of non-metro counties lack mental health services, and that only occurs in 5% of metro counties. And again, some similar issues with medical treatment. What outpatient services there are, rural persons have to travel farther to access them, and so what that means is if they have to drive farther, they go to less sessions, so they get less treatment, because unlike a medical approach where you may go and get something prescribed and come back in a month or 2 months, with mental health treatment, many times that could be weekly, bi-weekly, bi-monthly. So the more distance you have to travel to some kind of mental health professional is going to impact, that's going to impact your budget. If you're unemployed or you're limited in funds, you're not going to be able to go, meaning you're less likely to get the treatment that you need and less likely to improve your circumstances. I talked there at that last bullet, that primary care physicians tend to, especially those in rural areas, take on an even larger role in mental health. There's just not enough mental health practitioners out there, so your general practitioners sort of end up being your catch-all. They treat, they provide a lot of services, a wide variety of services. And while they may attempt to refer, if the individual that they're serving can't afford or chooses not to go to the adjacent urban area, then the general practitioner is forced to do the best they can and provide the service that person needs as best in their competency. This happens quite often when you talk about rural areas. Many times people from rural areas are intimidated by going to urban areas, and they don't want to go receive treatment there of any kind, and they'll even take substandard care if it means not having to go to to an urban area and get treatment. They don't want to go to the big city. They would rather stick with their doctor, even though the doctor may say that he doesn't have or she doesn't have the expertise necessary to provide adequate services. They would rather avoid traveling in that area. So always an issue. When we talk about some more facts related to rural psychology, there's significant depression rates in some areas, significantly in rural areas, exceed urban areas. Now, why that might be, I don't know. I don't have necessarily an explanation. That's a great, maybe something you all can discuss in your groups, why this might occur. There are higher suicide rates in teens and older adults in rural areas. And there's also higher stress when you start talking about. And one good point they make is that rural individuals tend to be more isolated socially, not a lot of interaction, so they tend to take on crises in a silo, and they don't ask for help because it's that self-determination, self-sufficiency sort of culture that's often attributed, especially to the farm workers. And one issue, as we talked there at the bottom of the slide, one of the main problems is, just like we talked about, the lack of affordable health care coverage or employer-provided health care coverage. There is even less mental health insurance coverage provided in rural Americans. So in rural areas. So especially when you compare them to urban Americans. So not only do they not have access, should you convince them, or they be convinced that they want mental health services, it's likely that if they choose to do that, they'll have to pay that for themselves or out of their own pocket. Where if they were to go to the general practitioner, they could pay their copay, their co-insurance, or pay up to their deductible, and they would receive some type of services. And many of these individuals do not understand. You and I may know, a psychologist provides this services differentiated from a counselor, differentiated from a psychiatrist, differentiated from a general practitioner. But they don't understand all those divisions. They sort of lump everybody into one giant mental health medical service provision group. They lump everyone together, so they don't understand that a doctor is that practices, a general practitioner has a lot less ability in regards to mental health than a psychiatrist. They see that they can provide the same medication, and there's not a whole lot a belief in talk therapy. So that's why they tend to go to that general practitioner, because health insurance, if they do happen to have it, will pay for that. And because it is often the most expensive health care in terms of paying for mental health, services because it's on a weekly, bi-weekly, bi-monthly, it's a much more regular basis. Co-pays are higher, then it's usually what gets left out. So with that, we've talked about some of the issues related to the challenges and a little bit about the strengths, and a lot of the, we've differentiated the issues that are out there in relation to rural medical and psychological healthcare. In the next segment, we're going to talk about some of the strategies that are under development to address some of these gaps, in these service gaps, not only in psychological areas, but in psychology, but in the medical treatment aspect as well. So please, at this point, go to Lecture 2 of the Medical and Psychosocial or Psychological Restoration of Rural Areas.